Good morning, everyone. I wonder if we could start our meeting, please. Good morning and welcome to this meeting of Perth Kinross Integration Joint Board, the final meeting of 2018. My name is Robert Peat. I'm the chair of the Integration Joint Board. That was endorsed or approved by NHS Tayside at its meeting on the 25th of October. I'm very pleased to be the chair of the IJB. It happened a bit unexpectedly. I was to be a member, but as circumstances, I'm pleased to be the chair of the IJB for the next period of time. I look forward to working with everyone to take the work that's already been going forward in Perth Kinross onto the next stages and continuing to improve the services for the people of Perth Kinross. I think we only have one person who's around the table who's here for the first time, is Karen Reid. Karen is the Chief Executive of Perth Kinross Council. I think, Karen, you've been in post since the beginning of September, but your first opportunity, obviously, to come to the IJB meeting, you're very welcome. I think it's really nice that the Chief Executive of Perth Kinross Council provides a chair with a coffee in the morning. I'm not sure if that's a one-off or if it's going to happen at every meeting, but it was much appreciated. I know Karen, so I can tease her a bit, actually. I worked with Karen in the care inspectorate, but delighted that Karen's now here in Perth Kinross as the Chief Executive. But you're all very welcome at this meeting and kind of look forward to a positive day. Just to perhaps say one or two things about the day. We're obviously starting a bit later. We had an earlier meeting of the Audit and Performance Committee. I would hope that we could finish, well, we won't finish, but we pause around 12:30 to have some lunch. Around then we'll see where we are with the agenda items, maybe for about half an hour. And then conclude our meeting at the latest 2 o'clock when we're going to have a session on public protection. So if we could try, and you could all try and accommodate that in terms of discussions and so on and so forth. So I'll do my best to get us there for a break for 5 minutes just before 2 o'clock. Our final item is the development of a public health strategy, and Drew Walker is here, and I think a colleague are going to speak to that. He has a brief presentation. We're going to see how we get to, where we get to with some time, but hopefully we'll be able to accommodate that presentation as part of our meeting. Do we have any apologies for the meeting today?
Thank you, Chair. We have apologies from Gillian Costello, from Nick Beach, from Dr. Daniel Carey, from Bernie Campbell, but we have Maureen Summers substituting, also from Fiona Fraser and Arlene Wood.
Thank you very much. I should have reminded you, you probably know that the meeting has been recorded and will be on Perth Kinross website and following the meeting. If anyone hasn't turned off their phone or put it to silent, could you please do that? Thank you. I'll move on to item 3 of the agenda, which is the minutes of our meeting on the 28th of September. You're happy to approve? Oh, sorry, I missed already the declaration of interest. Do we have any? No. I knew that, Rob. We were kind of just going to pass on to the next bit.
Yes, Pete.
Item 3, the minute of our meeting of the 28th of September. Are you happy to approve the minute? Are there any corrections?
Page
yes,
10, sorry.
Thank you. No other corrections, Maureen? I was only going to do amendments to the minute, but we'll take that update and then we'll come to matters arising, any other matters arising in a moment. But if you'd like to update on that.
So, Maureen, thank you very much for your point. We did, in fact, cover the issue of transport at the last meeting. I'd had a discussion with colleagues here within Perth Kinross Council, and we've been looking at our connections with the transport systems here in Perth Kinross, but also wider. NHS Tayside is taking this very seriously because the matters of change across the whole of health services in Tayside will have an impact on transport requirements. So not only locally for mental health, but more generally for the wider transformation that's happening across health, 2 areas of attention. I will not be able to give you the detail personally, but I've been able to give assurance that this is being looked at in detail in real time as the plans are being made.
Can I remind people if they're able to use a microphone when they would like to kind of speak would be helpful so that the room can hear everyone when they're speaking. Thank you. We have item 4, the action points update. And Rob, would you like to take us through the action points?
Thank you. So adult support and protection is the first one on the list, and as has already been announced, we're having a development session after the IJB today. Very grateful for the team who have put a lot of effort into preparing for that, so I would encourage all members to stay for that development event if they can. In terms of governance and assurance, this refers to risk management workshops that have been held this month. I was actually on annual leave when this happened. I don't know whether there's any further comment that Jane would like to make.
Thank you, Rob. I would just like to note that the workshops that we have held involved as many members of the IGB as were able to attend. We held 2 to try and maximise attendance. They were governance and risk workshops. I think that's an important point to try and ensure that our members understood the governance arrangements that are specific to us here in Perth and Kinross, and to understand how that related to risk. That work that has been done has then fed into a paper that has gone to the Audit and Performance Committee earlier on this morning, which set out a revised risk profile for the IJB and a revised risk management framework, both of which were approved.
Moving on to item 85, this will be covered by items on the agenda today. Moving on to improving Scotland's healthy future actions on ambitions on diet. We're going to have an IJB development session on that in March of next year. Moving on to look at item 93. We are at the moment in discussions with both Perth and Kinross Council and NHS Tayside about budget and development of that budget for 19 and 20. And Jane, I don't know whether you want to comment on 95. This is the draft 3-year financial plan.
Yes, this action arose quite some time ago on the back of the fact that the partnership had developed a 3-year financial plan, but the IGB only formally received year 1 of that, and that was 18-19. There was a commitment at that stage to bring forward years 2 and 3. However, that commitment has now been superseded by the planning arrangements for the next 3 years. We now have a fully developed 3-year plan that we're in discussion with, and I would like to propose that this action be superseded by the firm proposal that it will be a 3-year financial plan that will come forward to the IJB as one for approval when the financial plan comes forward.
Are members content with that? Yeah.
Moving forward, 99 and 100 are forward advance events in June of 2019. And then you will see item 101 and 102 and in fact 103. Each of those are going to be discussed today. And 104 again is for February next year.
Sorry, not in relation to previous minutes, in relation to the action point update, yeah. Just going back to item 93 on the described as informal discussions in place with NHS Tayside and Perth and Kinross Council. Have these been bilateral or multilateral discussions? In other words, has there been a roundtable discussion between officers of NHS Tayside, Perth and Kinross Council and yourselves, Rob and Jane?
So we have been having discussions most recently with Perth and Kinross Council. We are in discussion with our colleagues in NHS Tayside, and there is an intention for us to come together to have a joint discussion in the near future. In fact, there are plans afoot for us to be having that discussion, and the Chief Executive might want to reflect on that for us.
Sorry, the time scale for that is May 2019, which seems rather late.
I wonder if we could ask Karen to make a comment.
Thank you, Chair. So the Chief Exec of NHS Tayside and I have had a number of discussions, both together and with the partnership around the current budget position for 18-19 and moving into the future. So I think the timeline, colleagues correct me if I'm wrong, but May 2019 actually refers to the NHS Tayside budget process, but please be reassured that there's been a number of discussions in terms of the current financial position and indeed the short and long-term budget for the Health and Social Care Partnership.
Thank you, Karen. No other matters arising from our previous minute? No. Maureen, sorry.
Could I just bring up under number 85, the redesigning of the mental health and wellbeing strategy progress. It was just something, I don't know whether it's appropriate to bring it up here because it's mentioned in several reports further on, but just to make sure it gets discussed. There's the transformation team who are driving forward the centralisation of the mental health services at Carsview. Have called a meeting on the 11th of December in Dundee. I would just like to state that I think it's totally inappropriate that this meeting takes place at that time when there is still an inquiry going into the Carsview service itself. I think that there shouldn't be any pushing forward of the progress plans until the results of the inquiry. You don't know what the results and recommendations of this inquiry is going to be, so I don't think that the meeting on the 11th of December should be taking place. I certainly don't feel that I want to attend it because I think it's inappropriate, and I feel that that's the type of meeting I want to be at the appropriate time. So just to mention that, I really don't think that, you know, any progress should be made on Carsview until they know whether the service itself is fit for purpose, and that we won't know that till the result of this independent inquiry, which probably won't be until the spring. So
thanks, Maureen. I think an important point you make. I don't know, Rob or Evelyn, if you're able to comment on the meetings taking place.
I'll start if I might. There are three elements to this. The first, as you suggest, Maureen, is the independent inquiry, and that by its very nature is independent. So David Strang is leading that process, and that process will work its way through. However, there are two other elements of work that need to continue to be considered. One is the transformation program that was approved in January of this year, which is around the movement for buildings and making sure that the service is sustainable in the long run. And I believe that the meeting on the 11th of December is to do with that and some changes and some proposals that have come forward around that. The third element of work is that we now have a new leadership team in place for mental health services, and they're beginning to look at the care pathways, and they will be involving members of the public and public partners in particular in that discussion as that evolves. But this is very new, and that work has not actually started to the point that there's a discussion yet to be held.
But they'll still be looking at model of care, which NHS Tayside has been centralising acute inpatient services at Carsview, and we don't know that Carsview is how it's going to come out of this inquiry.
So I acknowledge what you're saying, Maureen, and I can reflect that comment back to the Chief Executive of NHS Tayside on your behalf. As the responsible officer for the mental health programme, at the moment I have been given instructions to continue with that programme of work, and we are continuing with that programme of work, so I will take your comment back to the Chief Executive of NHS Tayside and see whether that helps to vary the approach at the moment. However, we need to bear in mind that these services are working in real time and that we do have practical safety and clinical care issues to manage on a day-by-day basis. And it's in that respect that we need to continue with this work, because with the workforce challenges that we face, with the needs of individuals as they present themselves to us in Tayside, we can't wait for the independent inquiry to guide us in how we deliver the quality of care every day. We have a responsibility to keep that care going, and this redesign program is very much interlinked with our ability to sustain high quality services for people.
I know what you're saying, but I still feel that, you know, because of the nature of the inquiry, they're actually looking at Carsview itself to see whether, you know, it's fit for purpose. And I think it's a bit insensitive to continue with this, pushing this forward, when, you know, there are so many. I mean, I'm a carer myself, and I might well have been in that position for these 4 people who have lost relatives because of, you know, the treatment they had at Carsview. So therefore I feel that it's totally inappropriate, even and insensitive as well to the people, you know, at the other end of the inquiry, to push forward with this at this time.
Maureen, I think I think certainly we can convey your concerns, and as Rob says, he'll convey those directly to the Chief Executive of NHS Tayside. Eric, you would like to comment?
Yeah, if I can just come in, I mean, I understand Maureen's points, and in an ideal world, you would, of course, want the outcome of this independent review to be with us before now, or as soon as possible, and before any further decisions are taken around the redesign programme. However, this is not an ideal world, and as Rob points out, there are people's lives at stake, and we are working. You know, staff are working day in daily to improve the service provided. We can't stop that to await an inquiry, and completely endorse the view that we should proceed.
Okay, shall I move on to our next agenda item, which is agenda item 6, the board membership update. And you'll see in the paper that's before you that, as to note that NHS Tayside, as I mentioned earlier, kind of appointed me as chair of IGB at the meeting on 25th of October, and also Julian Costello, the nurse director of NHS Tayside, as executive board member, as one of the voting members of the IGB. I think it would be appropriate for me to comment at this stage that Gillian is actually retiring from her post at the end of March. So the timing is kind of difficult again. So I think what we would be saying to the IGB from an NHS perspective is that we would be identifying another member to take up the position in Perth Kinross IGB. It doesn't seem kind of appropriate at this stage for Gillian to, she's not able to come today, but to kind of join the IGB. But hopefully very soon we'll be able to identify a new member. We have 3 new members, 3 have started, 3 new members of NHS Tayside, and we would hope we would be able to identify one of those members to take the place on this board.
3 have started, and 1 more joins us at the very beginning of January, so it'll be a total of 4. And I'm confident that within that cohort, there will definitely be 1 to come forward, at least 1. Thank you.
So realise that there'll be a number of changes over a short period of time, but unfortunately circumstances are leading to yet another change, despite us having this report today. Also, you'll note in the report that Jim Fowler is retiring in May, but we're being asked to extend his position on the board for a 6-month period. I hope the board would be happy with that, and also to congratulate Jim in his forthcoming retirement. I don't think it's probably the first time maybe someone's mentioned that, Jim, but it's a wee bit away, but I'm sure that time will probably pass fairly quickly, but I hope the board would be happy to kind of endorse his member or approve his membership for a further 6 months. Okay. That moves us on to agenda item 7, our finance and governance part of our agenda, and 7.1 is the financial position. Jane, could you perhaps take us through the report and the key points to be highlighted?
Thank you, Robert. Before going into the report in detail, can I first note the change in the format of the report, which is unusual midway through the financial year. I have done that for a number of reasons. I've undertaken a self-assessment of the report that was coming forward. Undertaking that to ensure that we're reporting clearly on our reserves position, on our large hospital set-aside position and on services hosted out with Perth and Kinross. We've also included a further level of detail around our year-end forecast overspend. That's for two reasons. One, to reflect the level of detail that's been reported to other committees, and in particular the Perth and Kinross Council SPNR committee. We felt it was important that there was an equivalent level of detail coming forward to the IGB, and simply also to ensure that the finance report gave full and robust and transparent information given the level of scrutiny that we will undoubtedly be under given the financial position for this year and moving forward. So just wanted to note the reasons for the change in format, and either within the meeting or out with, I would very much welcome any comments that people have on that change. In terms of the forecast financial position, the position is based on the actual expenditure for the 6 months to 30th of September, apart from GP prescribing, which is based on actual expenditure to 31st July, as is normal GP prescribing expenditure is later in coming through. So I would point members to Appendix 1, which highlights that our forecast overspend for the year end is now £4 million. That's an increase of £847,000 from the position reported to the IGB at its last meeting. Despite all of the attempts across our services to, where appropriate, manage and reduce costs, the level of demand for services has continued to drive an increased cost, particularly in adult social care, where continued increase in demand for care at home and for complex care packages has driven an increased forecast overspend in the year. And within our health budget, our GP prescribing position has, the forecast overspend on our GP prescribing position has increased from the last report, reflecting a level of item growth beyond that which has been planned for. And for which we are looking to understand what that means at a GP practice by GP practice level. I would identify a further financial risk to the financial position that's not yet captured in the year-end forecast. The Audit and Performance Committee have just have presented to them the improvement plan in relation to the inspection of prison health care. The Audit and Performance Committee noted that there's likely to be both financial consequences in relation to the improvement plan, but also financial consequences in relation to a significant step up in prison population over the last few weeks that is likely to be sustained, not just in this financial year, but in future financial year. The potential costs of that are not yet reflected in this financial forecast. I would specifically point members to Appendix 2. We have deliberately provided some further information on the financial performance of services hosted out with Perth and Kinross. We can see that there are a number of services where there are significant overspends, but also some significant underspends. There is also significant levels of savings not being achieved. And I have taken the action to write formally to my Chief Finance Officers so that in future reports we can provide more detail to the committee on the financial performance in relation to the services hosted on our behalf by Dundee and Angus IGB. In Appendix 3 to the report, we are providing some additional information on delivery of savings. We can see that our overall savings programme on our core hospital, community and social care services, a savings target of 5.3 million and a forecast delivery for the year end of 4.8 million, and a huge achievement from across the service team to deliver a significant transformation and efficiency programme which will largely be delivered. I am happy to take any questions.
Jane, thanks very much, and it's obviously helpful to see the detail contained within the report. And for the board at this stage, the most significant point is the overspend for this year.
Yeah.
And I know, Rob, yourself and colleagues have been working very hard to identify a recovery plan, and I think more work is still required in relation to that. I know Karen and Malcolm Wright have personally been involved in supporting that and want to do that further in the very near future, and obviously something will come back to the board in relation to that situation. Yeah. But I wonder if there are any particular comments or questions anyone has in relation to the report you have today. Maureen?
The Appendix 1 sets out the budget in the first instance, so we can see a budget for service to carers of 709,000. So that's the budget. And the column next to that is the projected position against that budget. So we are projecting a small underspend against that budget.
Does that money include the 530,000 that you say specifically for implementing the Carers Act?
Yes, the budget includes that full 535,000 that was ring-fenced as part of the financial plan.
So a good part of that budget then has been spent on implementing the Carers Act?
Absolutely.
Right, and were carers involved in making the decisions there? Because I believe a programme board has been set up, but there were no carers involved in that. So hopefully that's going to be rectified now, because I have been approached myself, and I think another carer has, about that. But the thing is, the carers board was set up, and no carers invited, to come onto that at the beginning. There's already been 2 meetings taken place, and I just wondered if these meetings was where it was decided what the money was being spent on without carer input.
Perhaps Diane could help with that question. Diane, can you?
Yes, thank you. The Carer Strategy Group, which has been in existence for some time, was actually the group where I think maybe is represented by yourself, Maureen, and Bernie. So that's where there should be the discussions around the spend. The programme board has, as you say, just recently started, and it was identified that we absolutely needed carer representation, which I understand has been rectified.
Yeah.
Maureen, does that help?
Mm-hmm. Yeah. It's just the detail of it, so they can take that back, what the money's been, because that's a lot of money that's been spent on carers, on services to carers. So it's just if we could get some sort of breakdown. I know we can't detail everything, but roughly on how much has been used to implement the Carers Act, how much has been used for carer services, because it's just like the money for the Carers Act from the Scottish Government and the money that PCAF's already had for carer services have all been lumped together, and it's just to get some sort of breakdown on that.
Yeah, absolutely, Maureen. It's important that you have that and are able to feed back to your colleagues that are providing care services. And Diane, hopefully out with the meeting, can provide that detail. Sorry, Diane. Karen, do you want to comment first of all?
Thank you, Chair. I think it might be helpful in due course if the Chief Officer could bring forward a report about the impact of the Carers Act. So it's not just about the financial spend, it's about the impact that the Carers Act has had. That would be very helpful, I'm sure, for the board.
Karen. In the meantime, you'll be able to provide Maureen with some detail, Diane?
Yeah, absolutely. And we've also offered to meet with Bernie as well, so the public partners' role within the carer strategy, we can be clear about that, and obviously the support that the public partners can take forward along with other carer representation.
Thanks very much. Eric.
Thank you. Obviously the level of projected overspend for the year is very worrying, and from what we've heard earlier this morning regarding the prison situation, the only way seems to be up, and is 4 million going on something higher than 4 million. I just wanted to ask for some comments, some reassurance in terms of the future or the current and future budgeting processes. It strikes me, and you'll tell me if I'm wide of the mark here, it strikes me that the budget setting process that we undertook for 18-19 has had as its main objective achieving a balanced budget, as opposed to ensuring that we provide, we as an integration joint board provide the level of health and social care required for our population and the level of services that they're entitled to expect. So I guess what I'm saying is that, you know, was the 18-19 budget ever truly achievable, and can we ensure, and I know what the figures are looking like going forward, and the challenges that we face as an IJB going forward for making further savings, can we ensure that we recognise that the real problem here is the lack of financial resource as opposed to inefficient services, although we obviously have to improve efficiencies and so on going forward.
Thanks, Eric. I wonder if Jane and perhaps Rob would like to comment in relation to those points.
Can I firstly take the opportunity to just reinstate the point about the financial recovery plan? We, as part of the work of the partnership team, have done a lot of work to identify actions to address the financial position. They have been summarised in a formal financial recovery plan that is currently being discussed with the chief executives of both Perth and Kinross Council and NHS Tayside. Rob will want to speak about that shortly. In terms of the financial plan for 18-19, colleagues may not remember, but the financial plan did set out a projected financial balance position for core hospital and community services. It did not present a balanced position for prescribing, and it did not present a balanced position for inpatient mental health services. So if I take those two where we didn't expect balance, on prescribing we did expect to be able to bring our prescribing position down significantly to just under £500,000. We are £1 million away from that. Part of that was out with our control and to do with a Scottish Government decision to reduce the NHS Tayside budget to ensure that profits of the pharmaceutical industry in Scotland were retained. So that was out with our control. But there is absolutely an element of that prescribing overspend that is down to unanticipated growth. And we have to recognise that our planning assumption around growth may have been optimistic. And going into next year, we'll have to be very, very careful about the assumptions that we base our growth predictions on, and that we carefully take into account the GP engagement work that we're doing and what level of success that we believe that we will have in managing growth. If Hamish were here, what he would be saying, I'm sure, would be that the impact of the demographics in Perth and Kinross, the elderly population, is having a higher level of impact than we have expected in terms of the impact on the level of items that we're prescribing. The challenge for us is understanding how we can mitigate that through the work that we're doing with our GP colleagues. On inpatient mental health, the forecast gap in the financial plan was 1.5 million. The forecast overspend is 1.5 million. We are actually delivering on inpatient mental health in line with what we projected. It is having an impact on our forecast financial position, but that impact was forecast. And therefore, in terms of discussions with NHS Tayside, it's a slightly different discussion in that this level of gap was predicted. And so, in terms of our core services, however, on health, core budgets we're underspending. On social care, we're overspending significantly. The report sets out the unanticipated demand for care at home and for complex care. But you're absolutely right, Eric, as we look into next year, we need to make sure that our the data that we're using and the robustness of our planning is as robust as it can be. The problem is if we I wouldn't say a problem. Robustly financial forecasting is going to give us some very big figures going into next year, and that's just unavoidable. We can see it coming through this year. We will need to reflect that coming through in our financial plan for next year, and we can't try to minimise the potential forecast impact of that increased demand. But we then have to look at what we can do to absolutely address that in terms of new models and ways of effectively and appropriately managing demand for services.
I have Xander, Nick, and then Linda and Callum.
you. So I have a couple of questions. The first one, large hospital services. So obviously this is a budget that's decided essentially by NHS Tayside in terms of how much we contribute into that. I'm wondering if that figure is based on admissions from the PKC area into large hospitals, or is it just basically a across-the-board figure per head of population? Because obviously as a rural area we have less admissions to large hospitals, but we do have a lot more community hospitals to pay for, so it would seem a bit of an imbalance there if we're having to pay, essentially more. The other question I have is in relation to the reserves. We've got a reserves policy of 2%, which equates to roughly 3.8 million. Given that our overspend for this year is projected to be over 4 million, I think perhaps we might want to reassess our reserves policy to increase the level of reserves we're holding. If we're expecting to overspend on a more regular basis, it would seem good to governments to hold more reserves than we might actually overspend by.
First of all, in relation to large hospital set aside, the budget is absolutely based on admissions of Perth and Kinross residents to the specialties that are included in the large hospital set aside budget, and those admissions are almost wholly to within wards within PRI, into acute medicine wards within PRI. So that budget, and to accident and emergency. So the budget very much reflects admissions into the acute medical wards at PRI and in A&E at PRI. In relation to reserves, I think in drawing up the reserves policy, there was a recognition that we absolutely had to have the ambition to build up a level of reserves the same as any other public body, but our ability to do that is, as we can see, both in this financial year and when we come to look at the financial plan, is extremely compromised. What we would have to do to build up a level of reserves is actually it's a plan to over-deliver on a savings target, and whilst not wanting to go into the detail of our 3-year financial plan, bringing that into balance as it stands is obviously a challenge in itself, without adding on a further expectation of being able to build up a level of reserves.
Thanks, Jane. Nick, you have a question?
Yes, thank you. Like others, the numbers look very worrying to me, as you would expect. And my question is really around the recovery plan. So I recognise this is in process rather than an outcome at the moment. What I'd like to get to is a better understanding of risk and mitigation of risk and how that is being managed through the risk register. But en route to that, I wonder what level of confidence the team have got in terms of the space for movement within the recovery plan and the speed to which break-even might be achieved. Is there something that's realistic over a realistic timescale, or actually we're dealing with a different level of risk that might need a different approach?
Thanks, Nick. Karen, would you like to comment, and Rob?
Yes, thank you. So the first point to say is that under the papers, under recommendations 1 and 4, it notes that the IGB will be asked to approve the financial recovery plan. Can I just clarify it's for the 2 chief execs of the respective partner bodies to approve the financial recovery plan as per the integration scheme? So that's the first point I'd like to make. But Professor Beach, you make an important distinction, and actually a financial recovery plan is not just about finance, it's about the risk and impact on people's lives in terms of some of the decisions that we'll have to make. So at this moment in time, the 2 chief execs have asked for more work to be done on the financial recovery plan to take account of risk, impact and unintended consequence on people's lives and some of the decisions that we'll have to make. It therefore befalls the 2 chief execs to then enter into discussion about the impact in terms of, once we get closer to the end of the financial year, what the actual outturn is going to be. And we then need to decide at that point in time to bring it back to our respective organisations, to the council and indeed to the NHS board about the financial position. But all of that is being considered at this moment in time.
Thanks, Karen. Callum,
an answer to that.
Oh, you want to comment in relation to that, Colin, please?
Yeah, it was just a further response in that we had a board developments session of NHS Tayside yesterday, and the chief exec of NHS Tayside made clear that he was certainly willing to commit resources and staff in order to supporting the IJB, particularly in relation to the medical locum costs with inpatient mental health and the prescribing costs as well. So that was something that he gave us in his update yesterday, but it was just the development session.
Thanks, Colin. Callum, you.
Two questions, if that's all right, which are on different issues, both actually following on from questions raised by Councillor Drysdale and Councillor McDade. The first one in relation to the adult social care services and the overspends. We talked a lot about planning assumptions and the fact that our estimates have been off in terms of being able to anticipate changing demographics and also the changing complexity, the nature of some of the individual care needs. I'm just wondering if you could give more detail on what we're actually doing to update those forecasts to ensure that they're more accurate in future, both in terms of the planning assumptions for the budget itself, but also to allow us to identify these individuals and see if there's the potential to review some of those care packages, because obviously there was a previous saving that hasn't been met in relation to that.
Can you comment in relation to that?
Thank you. In relation to older people services around care at home, the work that we did around the review of care at home last year, we did set out a very detailed projection around new referrals and new people coming into the system. What we haven't been able to capture is the people who are currently in the system whose needs have increased, and it's that level of complexity. We have been working across the North region to identify a system that could actually begin to anticipate those individuals. And we have been engaging with the GPs along with other primary care staff to begin to look at that. We've just had an indication that those GPs should be able to go live in December, so we should be able to really test that out in the new year to begin to use a new tool to begin to identify those people.
Okay, thank you.
The second question.
Yep, the second question was following on from the question about large hospital set aside. There is a brief reference to the fact that the Scottish Government are keen to develop this issue further. I was just wondering if you had any more detail on how that will actually look, and in terms of the risks associated with that, because obviously we have this strange situation whereby we have the strategic planning responsibility, but the operational functions are still reserved to the acute division of NHS Tayside. Does that create problems in terms of budgeting for that, or lack of control over how savings are made, and also in terms of the governance arrangements around that? If there is an overspend, how would we deal with that? Would that be similar to the financial recovery planning process that we have here following on from remedial actions, or is there a different situation in relation to the large hospital services?
The Scottish Government commitment to support moving this forward with IJBs across Scotland has come out in a letter during 1819 to all boards, asking them to confirm their arrangements to take forward joint discussions about the large hospital set-aside budget. The NHS Tayside response to that was that such a forum was to be set up. One meeting of a core group has now taken place. That was largely the chief officers, the chief finance officers and our colleagues from NHS Tayside. However, that's largely discussing the sort of corporate level discussions about the theory of large hospital set aside, and what we have to do is move it from a theoretical discussion to a very real discussion with our clinical colleagues. And here in Perth Kinross, the fact that our large hospital set aside sits in beds in PRI has given us a unique opportunity to have really kind of meaningful discussions around how our strategy around older people on scheduled care can lead meaningfully to the disinvestment from beds. So whilst the Scottish Government, yes, are trying to support us in theory, my view certainly is the only way that this will be achievable is through meaningful engagement with our clinical colleagues. Doug, I don't know if you want to
add to that. Echoed that. So I'm the AMD that covers the operation unit in medicine, but I'm also a geriatrician who's a clinical lead who a lot of the community services, so I'm in quite a good position regarding this. Nowhere in Scotland's yet been able to use the large hospital set-aside. What we've been trying to do in P&K with the operational unit over the last year now is we've set up 2 different forums that are very much clinically led, which have got the physicians and the doctors and PRI, but GPs, primary care. One's called the Perth Clinical Forum. It's co-chaired by Hamish and myself, and the other is the Perth Unscheduled Care Board. And that is trying to put together clinically led models of care which will position P&K to begin to activate the large hospital set-aside. So, and I think in terms of Councillor McDade, you talked about this, because I've never heard that question before about, well, possibly P&K in some rural areas are in a bit of an uneven position compared to large cities because they will probably use less beds. I think in terms of the acute bed use that we use across Tayside from P&K, Angus and Dundee, we've got quite a good handle on it, and I can reassure you that P&K probably they sit around a bit in the middle because half of P&K is Perth City, so we have got quite a good handle on it. But in terms of, we need a strategic plan first before you can then have the financial plan, and then you can actually begin to shift the money. And I think that is the absolute key for around Tayside, but certainly for Perth and Kinross, to have this unscheduled care strategic plan that links up absolutely everything: the community hospitals, home care, rehabilitation, the action emergency, the function of PRI, absolutely everything, so that we're not working and making savings in silos and having effect in other areas. And that's the challenge of those 2 groups going forward over the next 6 months.
Okay, thanks very much. That's very helpful. Yeah, Callum.
Just to ask, at what point can we as the IGB expect to see that and give some strategic direction from our perspective on that?
Question. It needs to come here quite soon. It does need to come here very, very soon. It's just taken. This is very complicated, so I mean, it is taking a lot of time to put this together. And then at the same time, when you're trying to put this together, then there's a financial recovery plan comes in. So it's the absolute balance. You try and do the proactive strategic plan, but then you're challenged to do the financial recovery plan, and probably the financial recovery plan may have been the thing that's prevented that coming to this board in the next few months. So it's just where we are. As clinicians, we're not quite ready. It's extremely complicated. It's really important this lands here pretty soon.
Chair, could I ask that it's added to the action tracker list?
Absolutely.
So that we're keeping on top of that?
And I mean, that itself, obviously, it is very complicated and needs to be coordinated really carefully, and also, yes, again, the context of the wider transforming Tayside NHS Tayside agenda, that we need to obviously link all of the work locally into the wider perspective of NHS
I'm super
Tayside.
keen that the IGB's almost, at the minute, transforming Tayside and the Transformation Board and Tayside and the operational unit are kind of leading on this. That's not the right message. We, the 3 IGBs, should be leading on this. We've got to get to a place in Perth where we are leading on this. But hopefully that'll happen in the next 6 months.
Could I think Rob would like to comment. I haven't forgotten Linda. Colin, is your comment in relation to this discussion, or is that a separate question? Okay.
Just a quick further supplementary to Dr. Loudon again from the NHS Board Development session yesterday. The importance of wrapping up the contribution of the 3 integration joint boards in NHS Tayside into the transforming Tayside integrated clinical strategy was a clear message that went to the project staff working on that and presenting to NHS Tayside Board.
Thanks, Colin. Rob, would you like to comment?
Colin's actually covered the majority of what I was going to say, but it was just to reiterate that the reason that we have the report today on the Strategic Programme Board for Older People in Unscheduled Care is that those are the building blocks upon which this will now be built.
Thank you.
The question I wanted to ask is in connection to the progressive savings delivery, but I think Karen actually answered my question. It was what has been done to assess the impact on service users and carers during the transformation progress, and what support and assessment will happen to ensure positive outcomes and continued person-centred care for people that use services. But I think you answered it, but it would be useful to find out that or hear that information. The other question I wanted to ask was in relation to 7.1 when it talks about reserves. I wanted to know if there was any earmarked reserves allocated for the implementation of the Carers Act, sort of moving forward. And the last question in the same point, 7.1, it talks about Action 15 fund, and it was just to get understanding of what that is, because I don't know what it is.
Rob?
So probably a bit of a combination of both. Linda, thank you for your question. In terms of an assurance of involvement, the involvement of service users is critical to every one of our programme boards. So that's taken as read. We have to. We're obliged to take the opinions and the aspirations of our communities with us. As we are getting into these new programme boards, and they are relatively new, they're only months old, obviously there's an element of formation, there's an element of coordination, as we've talked about with NHS Tayside and its ambitions, and the point that Councillor Stewart has made about the Health Board working now to bring together the acute services strategy with the strategic plans of the IJBs. This is fundamental to making this work. So the future of PRI is not just about the IJB, it's about the future of acute services and so forth. So it's a very complex interdependency. The last question you asked, there were 3 or 4 things in there, and I think I'm going to ask Jane to speak about the earmarked reserves.
In relation to the Carers Act funding, as we noted when we responded to Maureen's question, that budget has got a very small underspend, so there'll be no significant amount of funding carried forward in the reserve in relation to that. The Mental Health Action 15 funding is specific Scottish Government recurring funding that we have received to meet a number of very clearly stated priorities, which I'm sure Rob will be able to summarise. We are forecasting slippage. It's probably a useful time to mention that as part of the recovery plan process, we have considered whether it would be appropriate to utilise any of the slippage on our Scottish Government allocations to support the in-year financial position, and it would be important for me to say at this stage that at the moment the draft recovery plan does not propose use of any of the Scottish Government allocations which have been allocated to us for very specific purposes.
Linda, we've been asked under item 9.2 to approve the use of the Section 15 money, so could we come to that question at that point in the agenda?
Okay. Chair, thank you very much. And just going to Jane's last point, I think we need to be incredibly careful about the use of slippage funds in terms of any to manage any overspend, and I certainly would not support and would like it recorded formally that I will not support the use of any slippage monies. Monies that have been given to the IGB for specific purposes must be spent on a specific purpose and will be recorded as a restricted fund in the accounts.
Okay, thanks for that, Karen. Lorna, Drew and Eric and Colin.
Thank you, Chair. Clearly we're in extremely challenging times, and from staff and capacity, I understand that is also very challenging. I understand there's also have been some offers of support for teams and discussions around with the mental health teams and social care teams, for example, with Hamish, around the support that the board could provide in terms of accelerating improvement actions, and I wonder if that could be confirmed and clarification around that. Is there an understanding that that offer has been made and how that's being taken forward?
I'm getting a red light. Right. There's certainly been a very clear statement of support for the mental health services that we host and the requirement to see improvement in those services. What we're discussing in our local mental health and well-being strategy is very much more about the community services and how they then connect with the acute services as a critical matter that will actually help to form the new view of what acute services will look like in future. So if I can refer back to what I was discussing earlier when I was asked the question by Maureen, the redesign of pathways of care will consider the joining up of what happens in communities in the future and the way in which, for instance, crisis services are delivered, and those services which require an inpatient stay, those things are intimately linked. So there's been a very clear offer from the Health Board to help with certainly that redesign process of the clinical pathways. And we've seen that in the investment that's been made in the new Associate Director of Mental Health Transformation. We're also seeing that in the appointment of Professor Keith Matthews, who's come in to lead and guide across the whole system a transformation of mental health services. And we do have agreement across all 3 IJBs and the Health Board to an alliance that will hold together the independent responsibilities of the 3 IJBs with the need of the acute services to modernise, so that in future residents of the whole of Tayside can look forward to a service that is much more joined up than it has been for many years in the past. And one of the issues we've picked up is that what was previously fragmented into the 3 geographies and fragmented between the different specialties of mental health now has a chance of coming together in a way that it hasn't come together for quite some time.
Can I just supplement it slightly? I mean, we met earlier on this week around the inpatient mental health financial recovery position, and as part of that discussion, Arlene Wood, the new Associate Director for Transformation, did talk about the offer of support. She did talk about some frustration around the identification and the sustainability of the support that had been offered, but she is absolutely clear that she was going to formally set out and have a discussion with Alan Gray at the board, because in the previous meetings that we've had, Alan Gray has been very, very clear that where support is required to bring that forward, and it will absolutely be taken very seriously. So I think Arlene is now prepared to kind of escalate that, and we will be sure to support her. I probably would say, so around inpatient mental health, I think we will be given the support that we need. I would still highlight a level of, choose my words carefully, lack of connectedness in terms of support for around GP prescribing. And whilst we're developing a lot of support locally and trying to build our expertise locally, we need to have much more local support coming from NHS Tayside out to Perth Kinross to support all of us in our attempts to address the GP prescribing issue. So we need to formalise that discussion. We're preparing to do so.
That's very helpful, thank you.
Drew, you have a question.
Thank you, and just by chance, my question relates to the final point you were making, Jane. First of all, thank you for the paper, which I found really clear and helpful. My question is around the prescribing issue. Clearly, I'm aware that part of the overspend is related to decisions made elsewhere, and I'm also aware there's an awful lot of work, really good work, going on around this. But there has been quite a lot of work happening recently across Tayside with input from Perth and Kinross around social prescribing, sometimes known as lifestyle medicine. And that has been worked up into quite a detailed set of proposals, as I say, with support from colleagues in Perth and Kinross and elsewhere. That was considered recently by the Tayside executive directors and was supported in principle. But there are investment issues around it. It's a classic invest to save issue. It will repay itself many times over. There's strong evidence from Doncaster and elsewhere, recently published in the BMJ and elsewhere. So my question really is, to what extent are you and your team engaged with colleagues in NHS Tayside in looking at the financial aspects, or the invest side, as well as the return on that investment?
No, thank you, Drew. The Primary Care Board that has been set up, for which we're having an update today, was due to have Andrew Radley and members of his team come at the end of last week. Unfortunately, the work around the financial recovery plan meant that in fact it wasn't that, it was the contingency work around the prison that happened last Friday meant at very short notice we had to cancel the work that we wanted to do with Andrew to understand the further work that's been done. We've already seen a high level invest to save case come forward. We wanted to engage further and understand how we might seek to build that into our financial plan, so we need to get that rescheduled. But absolutely, I think Hamish and the Primary Care Board acknowledge the invest to save opportunity that Andrew's proposals bring.
Thank you, Jane. that wasn't a trick question. I didn't realise that hadn't been able to happen, but thank you. I really welcome that.
Good. Thanks. Eric, you have a question or comment?
Yeah, a couple of questions just in relation to 4.1 adult social care services, and specifically on the issues that seem to be coming out here. If I can just quote briefly, there has also been an unanticipated increase in the number of new clients entering the mental health and learning disabilities service, as their needs have increased, and who were either in receipt of very low levels of care or not receiving any services at all previously. And I just wonder, is that pointing to a lot more work to be done in terms of both prevention and early intervention in the mental health journey at community level? That seems to be what it's telling me. And my second question, just the following paragraph, which is in relation to a point that Karen made about slippage, being used to, if you might say, paper over the cracks. It states here there's a non-recurring slippage in the Invergowrie project due to delays in progressing the building works, and that's £250,000. And the question is, why is there that delay?
Okay, I wonder if I could ask perhaps Diane and Evelyn if you'd like to comment in relation to the first point, and then Rob if you could comment in relation to Invergowrie project.
We will bring a further update following a full review around our complex care and our learning disabilities packages. But certainly in terms of early intervention prevention, we are beginning to identify some trends, certainly around younger people who are presenting with mental health problems, mild learning disabilities and autism, and also individuals who are presenting with very challenging behavioural problems. So that's the initial findings from the work we're doing. So certainly in terms of early intervention prevention, it's an area that we need to work with children's services as well as others, including housing as well. We've identified that there's certainly a partnership approach required.
Thank you. In relation to the project that's going on in Invergowrie, this is something that we've had planned for quite some time. And across Tayside, I think there are something like 19 people who've been in extended delay within the hospital services in terms of getting home, of whom 6 are residents of Perth Kinross. And the plan was to have 4 people put into the new facility that's being built in Invergowrie. However, my colleagues in housing inform me that there are quite serious technical problems with the land. So they're busy working at the moment to find an alternative site. So we're in active negotiations over that at this point in time, because we do not want to see this delayed any longer than it has to be.
Just for clarity, there's problems with the land. You're talking about legal issues?
No, I'm not. I'm talking about more serious issues around access and the land itself. There are challenges to the building that make it extremely difficult to deliver the project, and it's a technical thing that I can't give you detail about, but that information would be available.
Okay. Colin, you have a question?
Yeah, well, it was more a point of clarification. So I think if we just check under the second last paragraph of 3.4, the budget transfer there should be £142,000, not £142,000. Thank you for clarifying, Jane. The other point I was, or a couple of points I was going to make, just reflecting on Councillor Drysdale's original contribution regarding the accuracy of the budget in the first place. Obviously, the council recently has gone, in recent years, has undergone a number of transformation programmes. There are transformation programmes built into the programme of work for the Integration Joint Board, and indeed, as we've been talking about earlier, for NHS Tayside 2. I just wanted to reflect that the Cabinet Secretary for Health at a recent meeting of the COSLA Health and Care Board had suggested helpfully, I think, that reform and change does not necessarily mean that more money is required, and that in actual fact the real challenge for us is not to do, this is my words now, the real challenge for us is not to do incremental change, but when we talk about transformation, to do genuinely radical overhauling of the way that services are delivered in order to deliver services of greater quality for the same amount of money, or of the same quality for less amount of money, but to make the delivery of those services much simpler and clearer and streamlined. And I hope that's a message that those working on the transformation programmes are clear about. In relation to the issue about the reserves and about the financial recovery plan, it's probably also just worth noting, Chair, that the Perth Kinross Council are looking at the use of IJB reserves held by the Council, and about the use of charging monies too.
Thanks for those comments, Colin. Sander, you have a question? Or?
Yeah, it's in relation to some under 4.1 again, the adult social care services. It's in relation to the joint loan store stroke social care, occupational therapy stroke telecare. Now, the projected overspend is 270,000 of a 1.8 million pound budget roughly, and that's actually one of the biggest percentage overspends. From reading the paper, it doesn't seem to indicate that it's anything other than an increased usage, and I'm wondering how we're basically assessing, when we're drawing up our budgets, how are we assessing the demand for these things? Because obviously we know the population is getting older, we say that at every single meeting, so presumably we should be expecting an increase in these services and factoring that into our calculation. So I'm just wanting a bit of background on that.
I think if we were being honest and transparent, it's one area of the budget. I mean, the level of detail that we go into in terms of our financial planning is significant. However, in terms of looking at the impact of demographic growth on this particular budget, was one that wasn't looked at, potentially because it was such a small, budget. But what I can reassure you of is that in bringing forward the 3-year financial plan coming forward, this will now absolutely be considered. The increased costs, while not planned for, absolutely support the direction of travel in terms of our strategic direction. But we did not forecast the increase, but we will take that into account in our 3-year plan that's brought forward.
Karen, you would like to comment?
Thank you, Chair. Councillor McDade, I think it's important to note that this type of overspend is actually about spend to save. So where you actually see an increased spend in these types of areas, it actually means that those people who are getting older and frailer are provided with the right supports to remain in their own home and live longer and healthier lives within their own environment. But I think it would be fair to say that neither Jane nor I are social workers, and perhaps Diane might like to add to that.
Thank you. Yes, this is key to our strategy, both for older people and for people with mental health problems and learning disabilities. It's also probably important to know that part of the overspend was also the added number of staff within our telecare system, and that's also another key aspect of our strategy, particularly to improve the digital approach to telecare, and also to hopefully host digital and telecare services for other authorities as well, so we could potentially see a revenue from that too.
Can I just jump in there? Yeah, my concern is not actually around the fact that we're overspending in this area, it's the fact that we're not anticipating that we're going to overspend in areas that we are hoping to basically spend more on to save money in other places. That was more my concern.
Yeah, no, an important point, Sander, thank you for that. Can I conclude this part of our agenda? We are not asked to approve anything today other than note the various recommendations. I think important to reiterate Karen's point in terms of recommendation number 4, that actually, as Karen is the accountable officer for Perth Kinross Council, and Malcolm Wright, well, he is still the chief executive. Well, no, he's not the chief executive of NHS Tayside now. He is. Well, Grant Archibald has been appointed as the Chief Executive of NHS Tayside. I'm not sure when he formally takes up that role, but the Chief Executive of NHS Tayside and Karen, as the accountable officers, need to approve any recovery plan. But thereafter would come to this board for approval, for formal approval of the recovery plan. So I think to note, I think very helpful discussion. Thank you also for the officers for their clarification for some of these points. We're obviously continuing to work on the recovery plan, also looking at the next 3 years and preparing for the next 3-year budget. And I think we've got an understanding of the complexity of that in relation to the various transformation elements of the transformation programme and trying to bring that together. But I think it would be fair to say that in terms of the work between the IGB, the Council and NHS Tayside and finance colleagues, that I think there will be an improved approach that will help both the recovery plan and also the next 3 years. So thank you very much for that. Sorry, you want to make a point, Rob? Sorry.
Yes, just colleagues, just to inform you that we may need to ask the IJB to come together again to have a discussion about the recovery plan. As we get to the point where we've got more information, it would be very important that members of the board understand the implications of that. So please be aware that you might be called at relatively short notice to have a quite urgent meeting. Thank you.
We'll probably not do that on Christmas Day or New Year's Day. Just to reassure. I'm sure we won't. Thank you. Can I move us on to item 7.2? We're going to look at the work of the Audit and Performance Committee. And firstly, if I could ask Callum to give a verbal update.
Thank you, Chair. We held the Audit and Performance Committee just before the meeting of the Integration Joint Board this morning. The primary reason for this additional meeting was to agree to recommend new revised terms of reference for the Audit and Performance Committee for approval at the board today. This is work that's been going on for some time since I took over as chair of the Audit and Performance Committee, and both sought to clarify issues around membership, quoracy, reporting and private discussions, a lot of things that were happening already but were not necessarily formalised in the terms of reference, and also the reporting arrangements both to this committee and in other fora. In terms of the duties as well, slightly more important, we also updated the duties for governance, audit, standards, best value, performance and scrutiny, and also included the responsibility for monitoring complaints and freedom of information requests, currently something that did not have a specific way of being assessed by the IGB. In parallel with these discussions, there was a concern about the lack of assurance that the IGB had over clinical care and professional governance, and no formalised reporting arrangements directly to the board. We obviously in Perth and Kinross already have the clinical care and professional governance forum, but we were wondering what the best way to make sure that the board was assured about those arrangements. The original suggestion by the previous chair of the Integration Joint Board was that this would be a subgroup of the Audit and Performance Committee, but following discussions with board members and also with the chief internal and external auditors, we came to the conclusion that we thought that this would be, given the importance of clinical care and professional governance, that it would be better served as a separate and distinct committee of the Integration Joint Board. And this was discussed at a recent meeting of the NHS Tayside board, and as far as I'm aware was endorsed, and discussions concluded that perhaps this could be a model that could be adopted in other IGB areas should it be successful in Perth and Kinross. So we'll be asked to look at that later on in the agenda, but that's why that's now distinct from the Audit and Performance Committee. We also had two substantive items on the agenda in addition. One was the risk management update, which presented the IGB with a revised risk management framework, which included a new risk escalation process, which has actually been put in practice in recent weeks since it has been agreed. We also updated the risk register to provide greater clarity over the risks that are facing the Integration Joint Board, both those inherent risks and also the residual risk that's left over once we've taken a number of treatment actions. And I think that certainly from my perspective that was very helpful to have that set out, and also the fact that a number of the treatment actions which are due to be completed soon will also bring down the level of residual risk. As Jane mentioned earlier on in this meeting, we held a number of risk workshops, two of which were for members of the Integration Joint Board, which gave us a better understanding of how that risk register was put together, and we were also given the opportunity to try and measure some of these risks ourselves and compare them to the risk register that had been put together by officers, which I think was very useful to get that better understanding. After a number of discussions and also in relation to the next item, which I'll move on to in terms of the prison inspection report, we came to the conclusion that we would like to see the risk register presented at each and every meeting of the Audit and Performance Committee, so that when risks are escalated through this new process and then eventually appear in the register, that we as an Audit and Performance Committee are able to see them as soon as they become apparent, because there was some concerns about, again, a lack of reporting to the Audit and Performance Committee and consequently to the Integration Joint Board. The final item that we discussed was the HMP Perth inspection report. An inspection took place between the 14th of May and the 1st of June. There are 17 quality indicators, 16 of which were applicable to HMP Perth, and the results of the inspection were that 2 of those indicators were satisfactory, 7 were generally acceptable, but 6 were poor and 1 was unacceptable. There had been discussions around self-evaluation prior to that, and some of these improvement actions from the quality indicators did not come as a surprise. An improvement collaborative had already been set up to try and monitor progress on these, and a mock inspection was held in recent weeks, and an interim inspection has been held this week. The actions of the improvement plan have already started being put into place, and the verbal feedback from that interim inspection was positive, and that some of those actions have resulted in improvements. As I mentioned, part of the concern was why we hadn't had information, given that although that self-evaluation process was already taking place through the Improvement Collaborative, why the Audit and Performance Committee or the Integration Joint Board had not been aware of some of those risks and concerns that had been identified. So hopefully through the risk register, the new risk escalation process and the regular reporting to the Audit and Performance Committee, we should be able to prevent such a situation happening in future. As Jane mentioned earlier on, there were concerns raised about the increasing prison population, which has gone from 630 to 710 in recent weeks, and the concern that could further increase to a likely maximum of 730, which will clearly have financial implications for the Integration Joint Board. We also had discussions about, given that the slightly different nature of the slightly different nature of the way in which spending is allocated between the boards, given that when people become a prisoner in HMP Perth, they effectively become a resident of Perth and Kinross. So although there is sharing between the 3 IGBs in the NHS Tayside area, and also we have a relationship with NHS Fife about that, the committee asked for further clarification from the Scottish Government about those arrangements, and whether we could have clarification or indeed changes to ensure that we are not liable for an increase in population that might not necessarily be coming from Perth and Kinross. So that was what we discussed at the Audit and Performance Committee. I'm happy to take any questions if anyone has any on the meeting.
Callum, thanks very much for that update. Are there any questions in relation to those discussions? Linda?
I've got a few questions or observations about the terms of reference. So in the number 9 at the quorum, can you co-opt a person? Oh, is this not?
Come on to that.
Oh, right. My apologies.
The next
sorry.
agenda item.
Yeah,
So if we
okay,
could
thanks.
just hold on to those for a moment, contain your enthusiasm. Was there anything else out with the terms of reference? No.
Yeah, just one question. So, Councillor Purvis, I think you said that you were requesting from the Scottish Government information about the appropriate allocation of funding if prisoners did not originate from outside Perth and Kinross. Sorry, did originate from outside Perth and Kinross. But my understanding is that the increase in the prison population has been the consequence of policy decisions taken by the Scottish Government. Is that part of the question that you're asking of the Scottish Government? So it's not just about the division of funding for the normal population, but the increase in population as well as a result of decisions taken by the government.
Rob, someone?
Yeah, no, I'm. The budget that's been devolved when prison healthcare transferred to health boards across Scotland took into account prison population at that time. What it hasn't made allowance for is what happens when there's any significant increase. And what we're facing now is a test of what happens when we see a significant increase, when there isn't, I mean, there are not prisons in every IJB or every health board across Scotland. So what is the route with the Scottish Government to have a discussion about a significant increase in prison population and what that means for the health settlement from the Scottish Government to NHS Tayside or other boards who host prisons. From my discussions with Alan Gray, NHS Tayside, Grampian are facing similar issues, and we will work closely, probably through Alan, to have those discussions with the Scottish Government where it isn't just a Tayside issue, it's certainly a Grampian issue, and it'll be an issue across Scotland.
Rob, could you comment further in relation to Chief Executive's intervention?
I will, thank you. Members of the IJB were not party to, or not all were party to a conversation we had this morning at the Audit and Performance Committee. There's been a recent rise in the number of prisoners within Perth, and this is a result of a change in policy and also an increasing number of remand prisoners. So we have to be respectful of the fact that there are two major public bodies involved in this conversation. The prison governor is part of our executive team, and Fraser was with us just this week, and he is in contact with his chief executive to make sure that the approach that the prison system in Scotland is having to deal with will also factor in the impact that there are on services that support that prison population. So for us, our concentration is upon that health and care service for which we're responsible. And the reason we're having this debate is because if you look at the prison population and where the people themselves come from, there's a large proportion of the prison population that come from Dundee and from Fife, and a lesser proportion of people who come from Angus and from Perth and Kinross. But that shouldn't matter because of what Jane described as the way in which funding is given to the health board as a whole. However, we're now beginning to see the movement of prisoners from other parts of Scotland, and that will then begin to have an impact. So it's partly about the connectedness of the prison service with the communities, but it's also about the connection between two large public bodies. So on behalf of NHS Tayside, the Chief Executive, Malcolm Wright, is going to contact the Chief Executive of the Prison Service in Scotland and is going to bring his attention to the unintended consequences of some of this policy change.
Thanks, Rob. Sander, you have a comment?
Yeah, my question is this does the same policy in terms of funding apply for the medium and low secure units?
That's a very, very good question. But I think if we're thinking about the way in which we deliver services on a regional basis for mental health, for instance, there is an allocation that comes to NHS Tayside because of its support of other health boards. So that would be a local internal agreement based on the regional planning. It's not quite the same thing as meeting the health needs of a population that is under the control of another public body.
Maureen?
That's more or less what I was going to ask about. Does the population of Rahalian, being a regional unit, does that have an impact on NHS Tayside too?
Maureen, it does, but
yeah, that's just
it does. And however, there is a means by which the different areas that ask their people to come to Rahalian, they will contribute to that. And there are mechanisms between the health boards for making sure that there is a transfer of resources to cover that cost.
Okay, thank you.
Yeah, can I just make the point that I made in the Audit and Performance Committee earlier as well regarding this, which is that by sending effectively 15% more prisoners to Perth, to what in some parts is a Victorian prison, this, I mean, it's overcrowded at 630. So it's severely overcrowded at 710, or as I understand, perhaps 730 is the figure being aimed at here. And the result of this, in terms of the health of the inmates, is not insignificant, because the living conditions for remand prisoners in particular is very difficult, and I can see this resulting in a significant increase in mental health issues, which I'm concerned about as well, because that is another knock-on cost.
Thanks for those comments. Karen, would you like to?
Thank you. Just to add to Councillor Drysdale's comments, it is an issue in terms of mental health, it's an issue in terms of prescribing, but actually it's a fundamental issue about human rights.
Thank you very much, and thank you, Callum, for your update. That moves us on to the revised terms of reference for the Audit and Performance Committee. I think you have them before you. Callum's referred to the background to the changes to the terms of reference. Are there any questions, Linda? Yep.
So when you discuss the quorum, is there an option to co-opt somebody on to the audit committee if you're down in numbers?
You will? Yes, I'm being advised that it can have substitutes.
Right, okay. And the other question I had was number 5, any member of the IGB can attend the Audit and Performance Committee. So what's the process for attendance?
I think you can just turn
arrive.
up.
You notify the chair.
Yeah, I mean, yes, I mean, it's a public meeting, but certainly out with any member of the IGB is welcome to attend the meeting.
Okay, and I've got one more question.
Can I just pick up
carry
on those
on,
2 points? Those were 2 that we wanted to clarify, both in terms of substitutes. Although the Integration Joint Board's standing orders technically apply to all of the committees of the Integration Joint Board, there was no specific reference in the terms of reference to having substitutes. So it would be a substitute, but they would have to be from the same organisation or representing the same group of people. And also in terms of your second point about choracy, one of the issues was that we weren't able sometimes to hold meetings because we didn't have enough people, so we have lowered that, but that's in line with other audit and performance committees of Integration Joint Boards across Scotland.
I've just got one more sort of point I want to raise. There's nothing on the terms of reference about continued professional development for audit members or a skills matrix to ensure there are appropriate people within the audit committee to meet the audit function. Is that something that's going to be included?
Thanks for those points. Can anyone perhaps provide Linda with a reassurance that the members of the Audit and Performance Committee will be given appropriate training and ongoing development?
I mean, I think I absolutely recognise that that's part of the kind of best practice of making sure that the members are developed and can deal with the challenges that come forward. So I think we would take that back and actually have that an agenda item for the next meeting.
And sorry, Chair. And certainly that's something that we've discussed before. And although the risk and governance workshops were open to all members of the IGB, primarily was to inform the risk management update and processes that are going through the Audit and Performance Committee. So those things are ongoing, but absolutely we can look at that in our forward planning sessions.
And Linda, there's national training, because I've just become a member of the Audit Committee of well, I've actually just become the chair of the Audit Committee of NHS Tayside, and I'm attending a day's training in March. So I'm not sure who that's open to, but I could only imagine that it actually would be open to IGB members, but it might be worth if I give the details to see if it's possible for members of this board to attend that training.
Okay, thank you.
Karen, did you want to comment? And then Xander.
Yes, thank you, Chair. If I go to the standing orders, number 17.2, enables the IGB to establish committees. If I then take you back to Appendix 1 of the Audit and Performance Committee and the authority, number 3, I note that the Audit Committee is proposing that it would become a decision-making committee, and I wondered if there was a term of reference around the decisions that the Audit Committee would make. That's my first point. The second point is the role of the Audit Committee should be to approve and recommend to the IGB the annual accounts, and that maybe needs to come out more clearly in the terms of reference.
Thank you for those points. The second one, I think certainly yes. The first point in relation to Callum, the decision making.
Oh, sorry.
When we were having the discussions about the new terms of reference, we originally had retained the reference in the original terms of reference to the committee not being a decision-making committee. This was changed on the advice of the Chief External Auditor on the basis that in other integration joint boards they had come into difficulty about things like the audit plan, which they would approve anyway, and given that it was saying they weren't a decision-making committee, that they wouldn't be able to do that. I think the conclusion that we came to was that it was only things that were specifically referenced within the duties that the committee would be able to determine. If we don't think that's clear, we can still, I'm happy to look at that further, but it was subject to a lot of discussion.
Okay, thank you, Councillor Purvis. I'm happy with that explanation. I do think, however, there needs to be a clear line under Appendix 1, Item 3, that the role of the Audit Committee is indeed to scrutinise the annual accounts and make recommendations to the Integration Joint Board of the annual accounts.
I think we can certainly ask for the terms of reference to be updated to reflect those comments. Thank you, Karen. Sander?
Yeah, my question's in relation to point 9, the quorum. It says 3 members of the committee shall constitute a quorum. At least 2 members present at the meeting of the committee shall be voting members. And the question is around basically our standing orders as the IJB require that at least 1 member of each constituent body is there, one of the voting members from, so you cannot have the meeting basically if there was only councillors there or if there was only NHS Tayside representatives. I'm just wondering if we've decided that doesn't require to be included here.
Callum?
Again, this was something that came up in our discussions. In the original terms of reference, it does contain that provision that there should be 1 member from each of the parent bodies, along with the issues around the quorum itself. That had again caused problems for us in terms of scheduling meetings, given that at the moment we were only going to have 1 member of the NHS Tayside board on the committee. If he were unavailable, then we would not be able to proceed with the committee. So again, on the advice of the Chief External Auditor, we agreed that it would be appropriate to remove that. That was the reason for that.
Sorry, we've been asking the recommendations to approve the revised terms of reference. I wonder if you'd be happy for do you want to see it again when the changes are made and perhaps by email to just approve those, or are you happy that the changes are incorporated into the terms of reference? And the second recommendation is a replacement for myself. You'll note in the terms of reference that the chair of the IGB can't be a member of Audit and Performance Committee, so proposing that Nick Beach becomes a member of Audit and Performance on behalf of NHS Tayside, one of the two voting members. Are you happy to approve that?
Agreed.
I think he was already a member. We'd already agreed that at the previous meeting, I think.
Had we? Sorry about that.
It doesn't matter.
It's Lorna then. Sorry, it's Lorna Bush-Stewart who would be the second. Sorry, I got it the wrong way around.
Until such a time as we're able to get another member, because I think in terms of we've got the Clinical Care and Professional Governance Committee as well. Okay.
Yeah, if you can bear with us in NHS Tayside with our new members and clarifying who will be on which committee, and we can surprise you at every meeting as to who that might be. But thank you for your forbearance with all of that. Goodness, it's almost past, and I thought I would get past the first page of the agenda that I have in front of me, but let's try and do that, shall we? Well, maybe not in 2 minutes. But let's move on to item 7.3, which is the annual review of the standing orders. And Scott, can you tell us about this?
Chair, I'll be very brief.
Good.
At the last meeting of the IGB, the standing orders were submitted for review. It was agreed that the members be asked to submit any further comments to myself on the standing orders. The standing orders are resubmitted with the previous changes, and there was one further comment which we've added in at 19.1, just to formalise the consideration of any petitions that come to the IGB. So really they're just for the board to formally approve following the further comments.
Thank you, Scott. You're happy to approve the revised terms of... It's not the revised terms, it's the revised standing orders, Eric?
One point I've just noticed, I didn't notice when reading previously, but I have noticed now, so apologies for not flagging it up earlier. There seems to be a bit of duplication between 7.2 and 7.4. After the word interest in the second last line of 7.2, which speaks of a member not being able to take part in consideration of a matter if he has declared a financial or non-financial interest. That is actually covered, dare I say, more eloquently in 7.4. It's the same issue, I think, and so I think we should perhaps delete from and if to matter.
Yeah, we can tidy that up to make sure there's no other duplication.
Thanks, Eric. Maureen and Sandra.
On page 45, under 2.2, one member in respect of service users residing in the area, one member in respect of persons providing unpaid care. So that's like Linda and myself here, but there's no specific mention about a substitute. Should that maybe not be in there, but if the member isn't there that substitutes. It's just to tidy it up because it's not actually mentioned there or anything like that. And the other point I wanted to make, 2.8, for members not attending 3 consecutive ordinary meetings of the Integration Job Board and their absence was not due to illness or some other reasonable cause determined by the board, then they will be given a month's notice in writing and removed from office. Just like to comment, I'm very pleased to see that there because I've been coming to the IGB since I started, and prior to that with the CHP, and I don't know how many times I commented that there were, when the absentee list came out, that there were the same people not attending, and sometimes maybe only once in the year, and that were they the appropriate person. So I'm glad that this has been brought in now because that should put an end to that. We need people round the table, to contribute. So I'm pleased to see that there. But as regards to the substitute, that could maybe be.
Scott, can you comment?
Yeah. Sorry, Mike, can I just, your first question on the substitute, which standing order was that referring to? Yeah, so that just sets out what the membership is of the of the board. We also have within the standing orders we have the standing order on substitution. So like for yourself, you're substituting today. So that's as it has been.
I think 2.12 only refers to the constituent authority which nominated the member. So I presume that only refers to the voting members. So perhaps it could be updated to clarify around substitutes for stakeholders and other members, if that's possible.
Yeah, we can do that.
Thanks, Alan. Thunder.
It's 212. I think it's missing one very important word, which is only. In terms of proxy members shall receive papers for meetings of the Integration Board but shall be entitled to participate or vote at meetings in the absence of. Sorry, I have misread it. It's I think two sentences have been joined together there.
Yes, thank you very much. I'm going to pause the meeting at this stage. If I could ask you to be back seated, ready to start at 1 o'clock, and we'll all do very well to finish the meeting by just before 2 to enable the session this afternoon to commence at 2 o'clock. So thank you. There are sandwiches if folk would like to kind of help themselves, and be back to start at 1 o'clock, please. Thank you very much, everyone. Shall we restart our meeting? There are one or two people who have other commitments, clinical commitments this afternoon, and I'm going to ask if we could actually change the agenda around just a bit. And I would like us to deal now with item 10.2, the development of Tayside Public Health Strategy, and then move to the programmes of care, and I will go through those before going back to item 7.4. So if I could introduce Drew Walker, Dr. Drew Walker, Director of Public Health, and one of his colleagues, Lucy, you'll do the introductions. I was going to speak to us briefly about the development of a public health strategy for Tayside. Thank you.
So, the public health strategy. Really, this is, yep, that's picking me up now. This has come about as a result of a number of things. So there's a bit of a background. We've had a health equity strategy since 2010. So there's some foundations there, the communities in control, which some of you may be aware of. So we've had some foundations already around tackling health equity in particular for a while now. And there's been other things that have been going on, like the clinical services strategy, transforming Tayside as it's become. So we're trying to align things with that as well. And there's also, that some of you may be aware of, the public health reform process that's been going on at national level. And one of the things that's been looking at is developing some cohesive public health priorities for Scotland. So So all that's been going on, and we felt that we wanted to try and refresh ourselves and align our priorities with some of those other issues already. So we've kick-started a bit of a process to try and develop our own strategy based on a vision of a Tayside where everybody thrives, a human rights-based approach, health in all policies, prevention, community capacity building, all those kind of principles that I'm sure we'd all support. Equity, empowerment, being inclusive, and doing things in partnership and cooperation. We want to produce this as much as we can. So that's why we've come today, just to run through some of the things that we're thinking, and we'd very much value your ongoing input into that. I think there's an opportunity here to raise the public health agenda up everybody's remits and a public health approach and way of working. And there's also, I think, some challenges around sustainability of services and the kind of pressures you're facing with demographic change that this can help with. And inequalities and a lot of those other issues that are taxing us all. So what we want to do is take some of the key principles around our partners, which is what we're in the process of doing and why we're here today, and then there'll be an ongoing process of engagement to develop the strategy further. There's 6 main areas which are based on the national priorities. So Tayside being a vibrant, healthy, safe place to live and work. So that is going to be looking at things like housing, air, water, transport, green space, but also being a safe place to live in terms of things like health protection services, vaccination programs, and healthy workplaces, the Healthy Working Lives work. Flourishing in our early years, so addressing things like adverse childhood experiences, good mental health and well-being, so things like reducing stigma, suicide prevention, reducing the use of and harm from tobacco, alcohol and other drugs. So there's things in there that we would want to look at, like reducing drug deaths, which is a big issue across the whole of Tayside, reducing smoking in pregnancy and deprived populations, and then a sustainable, inclusive economy with equity of outcomes for all. So that's really about tackling inequity. And so there's things like that in terms of mitigating the impact of welfare reform, strengthening public protection arrangements, but also how access to services like screening programs and hot topic around things like the prison population and their access to health services is be key to some of that work. And in Tayside, eating well, being physically active and having a healthy weight. So good nutrition in the early years, getting people to be more active more often, prevention and treatment of obesity, oral health. So there's a lot that we can bring into this and that I think might be mutually supportive. And I think in view of things like health and social care services, some of the things that have come up today are relevant as well. How we work to promote sustainable services, things like social prescribing that Drew mentioned and stuff like that. There's a lot of different ways that we can build a strategy into how you're looking at your service developments, public protection arrangements, those kind of things. So I'll zip it there, but if there's any key points from your paper that you'd like to ask me and or Drew.
Okay, I'm very conscious that if I ask anyone if they have any questions that we could be here for several hours because it's so important, and I think the areas that you've highlighted just, they just go across all of the work that's actually undertaken across a whole range of partnerships. But I wonder if there are any kind of key points or questions anyone has, but if we could just keep this brief because we do need to get through Colin and then Maureen.
So 2 very brief points. Under the poverty and inequality, we're talking about a sustainable, inclusive economy with equity of outcomes. I wonder whether an equity of opportunity is a better phrase, because equity of outcomes is probably beyond the scope of a public health strategy. But specifically as an addition, I wondered whether chronic pain should be considered as part of a public health strategy. I was at the Carers Conference last week, and certainly it was a key topic that came up there, and I know from family and friend relationships that chronic pain can be an issue.
Thank you. I think there's probably a lot of key things, and I think it's about maybe taking some of these principles and looking at what the needs are of your population locally, and if any of those things can be highlighted as a specific need. If we feel that we're not getting equal access to service, for instance, around chronic pain management, well, you know, that's an inequity that we would want to be looking at in terms of service provision and outcomes. I think the opportunity outcome thing, the way I would see it, is that kind of goes together. You in terms of opportunities, I guess is, yeah, I think you're right. It's fundamental because we almost want to be skewing it so the people who need it most are getting the most easiest opportunity to do what they need to do, rather than the ones who can already have their own resources to take that opportunity. So I think that's an interesting thought and discussion, actually. Drew, did you have anything?
Could I just add, Councillor Stewart raised a really important point about equity of opportunity. My definition of equity is unequal provision for unequal need. It's not about everybody getting the same, it's about the fact of recognising that everybody is different and things need to happen in different ways for different people. And equity of outcome refers to the same. Equity of outcome doesn't mean equality, doesn't mean the same, everybody achieving the same outcomes. It means everybody achieving the best that can be achieved for them. So that's the distinction, why we need both opportunity and outcome when we address equity.
Yes, it's just under harmful substances there. You would be using, as an example, eliminating Hep C and reducing drug deaths. Where would you get the figures from for the drug deaths?
Where would we be getting them from? We have our own local drug death review process, but there is also a national database that feeds into. So we've got, I think, fairly good data on our own local drug deaths.
Would that include suicides then?
Suicide is a separate thing, but again, there is a suicide review process in Tayside.
If they're drug related,
yeah. Drug deaths are, they're separate from suicide. If somebody has taken an overdose clearly intending to kill themselves, then that's a suicide. Drug deaths is the unintentional overdose related deaths. So there's a distinction between the two, and we do have quite a good process of reviewing each and every case and keeping and evaluating information on all of those cases. So we should be able to provide good information on that.
I think it's actually the case that a lot of drug-related deaths are put down as accidental rather than intentional, unless, well, they don't have to have left a note, but it's obvious to be as clear as that before they class it as a suicide.
There has to be some other evidence that what they were doing was an intentional, and then it would be considered as a possible suicide. But there's
drug-related death, an accidental death.
Overdosing.
Still classes that a drug death.
And there's what we don't have such good data on at the moment, although there is work going on about this, is the overdose prevention. So in how many cases has a drug-related death been prevented by, for instance, administration of naloxone?
I wonder if we could perhaps not go into detail. I mean, locally there's a group, people obviously working together at Tayside-wide, the Alcohol and Drug Partnership in terms of drug-related deaths. It's just we are going to, it's been really helpful to get this
the ADPs do have good
development of the strategy, but we really are going to have to move on. Callum, is that a very brief point?
Just at a very fundamental level, how actually are we intending to deliver this strategy, particularly in relation to things that are out with the locus of the NHS Tayside board? Obviously we've got the example of the Children, Young People's and Family Plan across Tayside, where it's the local authorities and the health board that have all formed that and been part of that process and therefore able to deliver things. Just that one thing that jumped out, just as an example, was green space. Clearly that's the responsibility of the local authority. And yes, there's a move towards partnership working and these things can't be looked at in isolation, but how do you actually intend to deliver that if it's a solely an NHS
I don't think
strategy?
We're seeing this as solely an NHS strategy. This is something that we're also taking through community planning partnerships. So yeah, it's about our key partners, both in terms of health and social care and the broader community planning partnerships all having a place, because you're absolutely right, housing, transport, you know, we as an NHS, there's a limited amount we can do. We do need further involvement of that, and that's public health.
I think it would be helpful if that were made clearer, because clearly from the approach taken for the children, young people and families plan, that's evident and obvious as that's what it is, whereas from reading this that wasn't immediately obvious that was the intention. So
I wonder, Karen, before Xander asks his question, if you could comment.
Thank you. I'm very conscious of time, Chair, but my point is to Drew, actually. I think what we agreed previously between the 4 chief executives across Tayside is that there would be events in 2019 to actually look at the public health strategy and how it may be implemented and delivered upon.
Yeah, I think we will be looking at a further development phase. This is just to give a sort of initial heads up.
Yeah, would you like to Xander, can we conclude this? Drew, would you like to kind of make a concluding comment?
Thank you. I'll keep it very brief. Incidentally, we do produce an annual report every year for our own director, but also for the drug death group that Lucy read it, and we'd be very happy to bring that here for either for information or for discussion. And we produce an annual report from the suicide review group as well, and again we would be happy to bring that. But can I reassure everyone, this isn't a strategy for the public health department. This is a strategy for public health across Tayside. Public health is a multi-agency, multidisciplinary partnership where we do almost none of our public health work just on our own. And so what we will be developing will be developed in partnership with people sitting around in this room, other parts of the IGB and other parts of the community planning partnerships right across Tayside. So it's something for, I thought this was on, sorry. It's something for all of us to contribute to, but also something for all of us to benefit from. Thank you.
I'm going to move us on. Thank you very much for that. It was very brief, but I'll move us on to item 9, the programmes of care. And our first is the progress being made by the Primary Care Board. And Chris, you're going to give us a brief update of where the board is at with its work.
Thanks, Chair, and thanks for accommodating a change of agenda order as well. I just keep this very brief, as I think there's quite a lot of other business today. The new boards have been set up to seek to achieve objectives of the Health and Social Care Partnership in terms of the strategic plan, and will form the new strategic plan for primary care in respect to current and emerging issues. The board has met the Primary Care Board has met on 2 occasions so far, and I think Jane alluded to the fact earlier that we are scheduled to have a meeting last week, but for reasons beyond pretty much everybody's control, that had to be cancelled at very short notice. The board are essentially at this point trying to come together as a group of people from that I don't think have ever sat together as a collective group, and we're seeking to understand that collectively the very broad range of current issues and to better understand how those primary care issues are interconnected. We've met once as a strategic planning event, and work has been undertaken during that session and since to inform our future approach to a holistic primary care strategy. We'd hope to bring that forward in the early part of next year. I can go into a little bit of more detail in respect to what's contained in the report, but I'm happy to pause there if anybody's got any questions about that or anything within the report.
Thanks very much, Chris. I think there's a general point in relation to terms of reference for this programme board and the others. That I note in the appendix there are draft terms of reference. It's not one of the recommendations from the report that you're asking us to approve your terms of reference, but am I assuming that you are?
I think the term draft is probably due to the time scale in which the report was written, and more a case of the Primary Care Board hasn't in fact satisfied itself that it's comfortable with the terms of reference. I think once they are, and I'm fairly sure we're 99% of the way there, it would come forward to the board for ratification.
So for each of the programme boards we'll be able to see those and be happy that we're going to endorse them. Karen.
Chair. It's actually a point of both principle and practice. First of all, across all the programme board terms of reference, there is nothing to state that actually each programme board should not create unintended consequences for another programme board, and I actually think that's critically important, and it's certainly been forming part of our discussions in relation to both the budget setting process and the financial recovery plans. So it would be helpful if every programme board terms of reference has that stated. The second point is really a point of practice. In terms of the membership, it's highly unusual to see people's names rather than just posts. I think it would be helpful just to refer to posts rather than specific individuals. Individuals often come and go, as this IGB knows only too well. So perhaps each terms of reference could be amended to that effect. Thank you.
Colin?
It's again a point which is common to all of the programme board terms of reference, and it's the section on authority, whereby the boards are authorised by, and if the boards have to have further consideration of whether they're happy with the terms of reference, then this point can be addressed at that point. But the boards are authorised by the Integration Joint Board to prioritise issues and take decisions within the scope of their remit. But I'm not clear at what level that decision making stops and becomes a matter for the board, because it could be a significant service change, a disinvestment or an investment that would require or that should properly come to the IJB for each of those four programme boards. So for that point in particular, for all four of the papers, I would like to know what level that decision making stops at and where it comes to the IJB itself.
Be happy to revert to Rob, but just picking up on that point before I do, I think that you make a good point, and I think the issue is really around operating within the realms of whatever the current strategy is. So we're at this point where we're trying to refresh our strategy across the HSCP and create a new strategy for primary care. So once that strategy is approved and endorsed, my interpretation would be that the board would be operating within the realm of that strategy. Rob.
Thank you, Councillor Stewart. I agree with you, and it's quite clear that in these programme boards at the moment we have a mix of operational and strategic issues that are being discussed. It would certainly be my intention that the strategic planning group that sits over this, the strategic planning board that sits over this, will have that responsibility for balancing across the four programmes of work, as Karen was alluding to. The second thing is that for any major change in strategic direction, I would have an expectation it would come to the IJB. No question.
Linda?
Hi. Under membership, if the plan is to have carers and service users on these boards, could they be put in the list of people attending?
Yeah, so make sure that happens. Okay. No other comments? Thank you, Chris. And we're going to receive update reports at each of the meetings of the IJBs, and we'll see the final draft of the terms of reference. Okay, thanks very much. Can I move us on to 9.2, the mental health and wellbeing programme? Evelyn?
Okay, the Mental Health and Wellbeing Programme Board is very much in its infancy, so what you're seeing today are some fairly high-level proposals in relation to the key areas and key themes that we want to take forward. We've had a conversation today already about Commitment 15 and ADP monies. The proposals around these for year one have been approved by the Strategic Planning Board, and really today, although this says approval, I think it really probably needs to say endorse. These have had to be submitted in a timely fashion to Scottish Government. I suppose a description of Commitment 15 I think was asked for earlier. So Commitment 15 is one of the commitments that's given in the Mental Health and Wellbeing Strategy for Scotland. There are 40 commitments, and this is number 15 of them. So this is really about integrating services across accident and emergency, police custody, primary care, community, and it's a very much a focus on mental health and well-being and early intervention. So it's important to say that the board has given a commitment to looking at improvement work around these pathways, to really look at gap analysis, where there's duplication. We do know within the mental health world there's quite a lot of handoffs, so we've given a commitment to do some improvement workshops around that. They haven't been set up yet, but they will be. So in relation to Commitment 15, there is the funding proposals that are there, which I can take you through if you wish, but I'm conscious of time. So the board have given a commitment to look at Action 15 monies. They've also given a commitment to look at ADP monies in relation to the Health and Social Care Partnership, working with the Drugs and Alcohol Partnership. We've given a commitment to review the strategic groups. We're going to set up a workshop to look at the strategic planning groups that sit underneath the board, of which we have 4. We have the Mental Health and Wellbeing Strategy Group, the Learning Disabilities Group, Substance Use Strategy and Autism Strategy. So quite a lot of work already happening, and we've given a commitment to review that and to probably look at more clinical support to those groups as well. And lastly, we've given a commitment to look at complex care. You've heard a little bit about that from Diane today. I'm not going to repeat that. But what we are looking at is looking with the mental health leadership team to create an alliance across Tayside to look at how we commission new models of care. So in relation to the strategy, we're looking at early intervention and prevention for our people with complex care and mental health issues. And we need to create commissioning models that are going to look different, and certainly solutions around better housing options, strengthening community service models, looking at positive behavioural support within our teams, so that we're working better with people with complex needs. So we're looking at designing a whole system review in relation to what do we need for inpatient services, what do we need for crisis services, but predominantly what do we need to deliver in terms of community. So in relation to the programme, as I say, it's early days. We're still tweaking around with the membership. We still haven't managed to get some clinical leadership support there, but I know that's been worked on. So I'll just leave it at that. The funding is there for year 1 for Commitment 15 and for the Drugs and Alcohol Partnership, and you will see that there's funding for local communities, but there's also funding for prison healthcare. And all the IJBs across Tayside have committed to the prison healthcare funding around mental health, drugs and alcohol. So,
thanks very much, Evelyn. I think Rob would want to comment further in terms of Commitment 15 and ADP monies.
I'm running out of no, that's fine. Yes, I just wanted to tell the board that the Scottish Government gave us tight deadlines to turn around proposals for both Commitment 15 and the alcohol and drug spend. So while we are bringing detail of that to you, it's probably something we should spend some time discussing in detail as a board, perhaps at a development session in the future, to help everybody understand the reasons why those choices have been made. And just to reiterate that the Commitment 15 money was about employing additional mental health workers, 800 across the country, commitment of £12 million in the first year, rising to about £35 million in 4 years. And they're specifically targeted on the police custody units, on prisons, on accident and emergencies, and on